2-minute anesthesia, rhabdomyolysis. Please like and subscribe to the channel. The term rhabdomyolysis can be broken down to mean striated muscle breakdown and thus release of cellular contents into the systemic circulation. The incidence is 15% of all cases of acute renal failure, and up to 40% of patients with rhabdomyolysis can develop acute renal failure. The etiology is broad and can be traumatic or atraumatic. Traumatic causes include crush injuries, electrocution, and entrapment. Atraumatic causes include prolonged immobilization or exertion, temperature syndromes, a range of drugs, infections, and metabolic causes. Risk factors are broad and can be endogenous or exogenous. Endogenous causes include increasing age, multi-system disease affecting the renal, hepatic and thyroid systems, metabolic muscle diseases, and finally exogenous causes involving alcohol, major surgery, strenuous exercise, and drugs affecting the CYP450 system. The clinical features are based on the timing of presentation. The patient may present with features of the underlying disease pathology, i.e. evidence of electrocution or crush injury, as well as muscle injury, so pain, weakness or dark urine. As the disease progresses, patients may have systemic features, fever, nausea and vomiting, malaise, and then they may have evidence of renal impairment with reduced or absent urine output. Following insult to the skeletal muscle, there's a range of physiological effects. Ions move down the chemical gradient from a high to a low concentration, and therefore sodium and calcium moves in addition to water, and phosphate and potassium leave. In addition to a range of cellular components, these include uric acid from DNA, creatine kinase, which is an enzyme, and myoglobin, which is involved in oxygen delivery. Myoglobin moves to the kidney and binds within the tubules to TAM horsefall protein to form casts. These casts precipitate and block the tubule and therefore lead to a reduction in renal function and thus acute kidney injury. This increases under acidic urine conditions. The increase in intracellular calcium results in a range of physiological effects leading to skeletal muscle injury, necrosis and death by 4 mechanisms: increased free radical production, mitochondrial dysfunction, persistent muscular contraction leading to loss of ATP reserves, and finally activation of phospholipase A2 leading to the breakdown of cellular phospholipid membranes. The diagnosis of rhabdomyolysis requires a high index of suspicion, in addition to blood markers. These include 2 key markers, which are previously described on the last slide. So myoglobin. Unlike CK, it has a short half-life, and therefore late presentations can result in missing the diagnosis. Conversely, creatine kinase has a half-life of 36 hours and a cut-off value of approximately 5 times the upper limit of normal reference range is commonly diagnostic. We can also assess for urine dip for myoglobin and assess complications, i.e. renal function. The management principles are relatively straightforward. First of all, stop the precipitating cause if there is one, i.e. a drug, and then infuse fluid. Due to the movement of fluid into the muscular compartments, there's a risk of hypovolemia and pre-renal acute kidney injury, and therefore fluid management is essential. If the muscular compartments are tight, they may require fasciotomies. Additional treatments include the alkalization of urine with sodium bicarbonate to reduce the precipitation of casts, and finally renal replacement therapy. Rhabdomyolysis has a range of complications as discussed, so compartment syndrome due to high compartment pressures, renal impairment, DIC, and a range of electrolyte disturbances. Due to the release of phosphate and potassium from the cell, patients are at risk of hyperkalemia and hyperphosphatemia, and there's uptake of calcium into the cell, initially leading to hypocalcemia. However, due to ongoing muscular damage and reduced renal clearance, patients are at risk of hypercalcemia.